All right, good morning and good afternoon to all those who have taken the time to attend this session, and thank you for coming. Over the next 20 minutes or so, we'll cover the disease spectrum, the clinical disease spectrum that COVID-19 can cause. In terms of introductions, my name is Vikram Mukherjee. I'm an intensive care physician based out of New York Hospital, where I direct the medical ICU, and I'm also the medical director of our special pathogens program here at Bellevue Hospital. I have no relevant financial disclosures here. And as we go into the clinical aspects of COVID-19 and how SARS-CoV-2 affects the human body, I think it's relevant to just remind ourselves of the biphasic response that is often seen translated to clinical illness at the bedside. As we know by now, there's an initial viral or a viremic phase, which is usually stage 1 and stage 2, followed by aggravated host response, which usually manifests itself, as you see on this diagram, in stage 2 and stage 3. And it's good to remind ourselves of this biphasic response because the treatment modalities, the clinical findings that we see at the bedside are often pertinent to where in the phase the patient presents himself or herself. Just going over the different ways that SARS-CoV-2 can affect a patient, there's all the way from asymptomatic or pre-symptomatic all the way down to critical illness. And just going over some basic features, an asymptomatic or pre-symptomatic patient, which is up to 30% of patients who have this infection, have no symptoms whatsoever, no fever, no cough. A screening test, if the patient has had known exposure, is often positive, and the patient is recommended to be isolated, of course. This is clinically challenging because from a public health perspective, given that around 30% of patients will have no symptoms at the time of infectiousness, makes contact tracing quite difficult. And that's one of the challenges that every public health department across the world might be facing as we speak. Going on, there's mild illness, which is honestly just a little bit of fever, a bit of cough, anosmia. Testing again is diagnostics testing and isolation is recommended. Moderate illness is when we have a patient who has lower respiratory infection, either an X-ray with some infiltrates or ground-glass opacities or not further imaging, but the patient is not hypoxic and possibly can be taken care of at home. The two latter categories, severe illness and critical illness, is where in-hospital medicine comes into context. Severe illness, as defined by the WHO, is hypoxia to less than 94%, tachypnea, lung infiltrates more than 50%, and while critical illness is the other end of the spectrum, where you have respiratory failure, often requiring intubation, proning ECMO, shock with multi-organ failure. And this is where not just the viral response, but also the host immune response plays a significant role in the clinical manifestations. Of course, testing overall is diagnostics testing. And anytime you have a positive test, isolation to prevent further infection and further spread is advocated for. Now, again, here is the viral replication phase. The first 3 or 4 categories is where there's viremia. The last 2 or 3 categories is where the host immune system becomes dysregulated and plays a significant role in the clinical spectrum. And again, following these 4 or 5 categories, it's important to know that where the patient lies. Early on, when there's active viremia, viral replication, antiviral therapy, especially FDA-approved remdesivir, has a significant role to play. Early on, especially in the outpatient setting, when there is still an asymptomatic or mild illness, moderate illness phase, and antibody therapy has been shown to have a decrease in ED visits and hospitalizations. In the 4th and 5th phase, where severe illness and critical illness have are manifestations and the host immune system is playing a significant role, is where anti-inflammatory therapy, for example, steroids, have a significant role to play and has data to show that it might improve outcomes. Again, going over the last row here, the first one, where you're asymptomatic and pre-symptomatic, is mostly about infection control and public health contact tracing. Mild, moderate, and severe illness is clinical monitoring, supportive care. Severe illness is usually when hospitalization is advocated for, supportive care with oxygen therapy, specific therapy such as remdesivir and dexamethasone. And when you have critical illness with multi-organ failure, need for intubation, or especially renal failure, this is when the patient enters into the ICU and often almost gets steroids and possibly remdesivir as an antiviral agent. So the point I'm trying to make in this very busy slide is that we as clinicians have to recognize that there are 5 different categories of illness, and the challenges faced are different compared to in context of where the patient is. If it's here, the first phase, it's mostly the patient should be okay. It's mostly about contact tracing and isolation and social and isolation. While in terms of critical illness, it's more of an ICU supportive care paradigm where critical care support and specific therapy are mainstays of treatment. So following this trajectory, there are different ways that patients can present. One is onset of symptoms, and the patient recovers, does just fine. The patient may be sick enough to present to the ER, and at that point can get admitted to the floor or to home. Once the patient is discharged home, a period of monitoring following which the patient is usually recovers and gets better. The patient may be admitted to the floor, following which usually recovery happens and then the patient goes home. However, a significant fraction continue to develop and progress to critical illness, worsening hypoxia, admitted to the ICU, most commonly with the bilateral infiltrates meeting classic criteria for severe acute respiratory distress syndrome. Many of them, because of the dysregulated host immune response, progress to a cytokine storm. And among all the organs that fail in our ICUs, renal failure, new onset AKI requiring renal replacement therapy was by far the most common. And sometimes the patient recovers. Off and on, unfortunately, when multi-organ failure sets in, death is an unfortunate terminal next event. And honestly, the challenge we face now that we know that there are different trajectories of how a patient can manifest is try to delineate which patients will do better and go home with full recovery, which patients will be admitted to the ICU and develop severe acute respiratory distress syndrome, which with requirements for high flow nasal cannula, with requirements for intubation, proning, and often on ECMO, which patients will require renal replacement therapy and have overall a poor outcome. So now that we have somewhat of an experience with this disease and we have been acquainted with SARS-CoV-2 for almost a year now, it's time for us to use some clinical tools to help differentiate overall outcomes in terms of recovery versus ICU admission and death. Many risk factors play into these outcomes. There are clinical risk factors and non-clinical risk factors, and I want to describe a little bit about the non-clinical risk factors, which have so much to play in how a patient does. So here's New York City data, and as you can see here, patients who belong to Hispanic or Latino or overall an underserved, underrepresented minority do much worse than patients who are traditionally non-Hispanic white. So for example, this is rate per 100,000 population in terms of hospitalizations. People who are of color, people who are of underrepresented minorities have a higher rate of hospitalization and severe disease than people who are not. This trend continues in New York City, for example. People who are generally underrepresented and of color have a higher rate of cases, have a higher rate of hospitalizations, and have a higher rate of death. So just being of a certain ethnic and racial background puts a patient at a higher risk of death, hospitalization, and infection compared to being of Caucasian descent. Now, there are many, many factors playing under this discrepancy. One, we strongly feel that COVID-19 magnifies the social disparities that already exist in healthcare access and healthcare delivery. Secondly, as you can imagine, one of the principles of good contact tracing and social isolation is being able to work from home. And many people of color may not have the luxury of being able to work from home and are compelled to go to work and get exposed to potential infection. And lastly, we're looking at it closely, but there might be a genetic predisposition of patients who are of color to get a severe form of this disease. But to cut the story short, if you are a person of color, you're already more predisposed to being infected, being hospitalized with severe or critical disease, or dying from SARS-CoV-2 infection. More interestingly is, especially in New York City, COVID-19 cases, hospitalization, deaths by poverty level. And again, this underlines the emphasis on social disparities and access to healthcare. If you live in an area which has a very high poverty level, you're more likely to be infected, more likely to be hospitalized, and more likely to die of SARS-CoV-2. And again, the reasons underlying this are similar to what we spoke in the earlier slide. Access to healthcare, ability to self-isolate, and social distance are much more constrained when you come to people living in high to very high poverty levels. What's very interesting is this paper that came out last week from NYU, which shows that the proportion outcomes of patients with COVID-19 by race and ethnicity. And essentially, once you're admitted to the hospital, your outcomes are very similar, irrespective of whether you're white non-Hispanic, Black non-Hispanic, Hispanic, Asian non-Hispanic, or multiracial. So it's essentially, the social disparities are more of healthcare access than healthcare delivery. And this is important to know that when you are in the ICU, for example, your chances of dying are actually very similar across multiple races and ethnicities. So it's very interesting that the discrepancy that we see here is more about healthcare access than healthcare delivery per se. Moving on to clinical risk factors. As you saw from those two algorithms in the previous slides, patients can either remain completely asymptomatic, have a mild or moderate form of illness, and recover with 100% baseline functional status, versus a much more severe or critical illness route where the patients either stay in the hospital and require supplemental oxygen, end up with fibrotic lung disease, or end up in the ICU and recover not to the complete baseline that they came in with, but to a part of it, or die of SARS-CoV-2. And this underlines the need for predictive scores. It would be immensely helpful for us as clinicians at the front lines to know that, yes, this patient is going to recover, can go home. Yes, this patient is not going to do so well and needs closer monitoring in the ICU. Or even more importantly, this patient, come what may, is not going to do well, has a 90% mortality, and resources should be targeted more towards goals of care discussions rather than aggressive ECMO and other state-of-the-art critical interventions. So the need for predictive scores are 3 in number: identify high-risk patients so we can keep a closer eye on them, pre-deterioration escalation of care so that we don't wait for them to be hypoxic or peri-arrest before we escalate them to an ICU. And this is relevant in COVID-19 because escalation of care, as you can imagine, takes time. You have to don your PPE, you have to go into the room. It takes an extra 7 or 8 minutes to address an escalation of care. And those 7-8 minutes when dealing with an unstable patient can mean a significant difference between life and death. And goals of care discussions, So for example, if you know that a patient, come what may, has close to 100% mortality, those are patients that we should involve our palliative care experts and our intensivists to discuss goals of care rather than go down a route of aggressive critical care intervention. This has relevance in surge planning where you're trying to protect your beds to critically ill patients who would benefit most by critical interventions. So in this context comes a beautiful score published in the BMJ in September called the 4C score. It takes into context these 8 parameters: age, sex. We know that older age patients with an older age do poorly. We know that patients who are of male gender or male sex do worse than case-controlled patients of female gender. Number of comorbidities, especially hypertension, obesity, diabetes. Respiratory rate and oxygen sats, which give you an insight of how compromised the patient's respiratory status is. GCS, encephalopathy, BUN as a marker of renal failure, and CRP as a marker of the patient's host immune system that might have gotten dysregulated by now. So taking these 8 parameters into context comes a very elegant 4C score, which has a really good predictive value in being able to predict mortality and ICU outcomes. So here on the left is an AUROC curve, which compares the 4C score here with a curve 65 with just age and with a 50-50 coin toss. And as you can see here, the 4C score outperforms most well validated scores in terms of being able to predict poor outcomes in terms of good sensitivity and good specificity. On the right here is another reflection of the same score. And shows the discriminative performance of the score to predict in-hospital mortality. And as you can see here, the 4C mortality score has around a 77% predictive value in being able to do that. And this is very comparable compared to something that we've been using for years, the curve 65 or SOFA score and so forth. So something that has promising data in it, and in my mind should be used in patients who are being admitted to the hospital to risk stratify them on whether they'll be doing well and going home, whether they'll do poorly and come to the ICU. Moving along this, earlier we thought that, especially in January and February of this year, we thought that SARS-CoV-2 was a predominantly respiratory infection. And yes, that's usually the case when it starts off, but as things get worse, SARS-CoV-2, COVID-19 quickly involves multiple other organ systems. As you can see here, acute respiratory distress syndrome is by far the most common manifestations, but acute kidney injury, we know from our spring experience that up to 30% of patients in the ICU had AKI were bad enough to necessitate renal replacement therapy. And this took us off guard because we were looking at the surge capacity in terms of ventilators and so forth. We were not as conversant with the amount of renal replacement therapy that these patients will need. Stroke, coming along with venous thromboembolism, a sign that SARS-CoV-2 infection is highly hypercoagulable for multiple pathways. All three of the workhorse triads seems to get activated from the endothelial inflammation that SARS-CoV-2 can cause. So strokes and venous thromboembolism are big manifestations of SARS, of this infection in an extrapulmonary fashion. Vasoplegic shock, mostly from this cytokine release syndrome that is being debated now. And of course, this dysregulated host response, which often causes the vasoplegia as well as high inflammatory markers. With that, I will pause for questions. Thank you for time. Again, the take-home points that I would like to urge from this is that SARS-CoV-2 COVID-19 infections can cause a large spectrum of disease. Most of your patients will do just fine. They might not even be symptomatic. And the challenges there are social isolation, are distancing, are case control. A small fraction, but given how large this pandemic is, the numbers are still very significant, will require hospitalization, will require ICU resources. And it's really important that we as clinicians are able to discern which of these patients will do better and go home, which of these patients will need a closer eye and will need to be monitored throughout the ICU stay. With that, I will pause. Thank you for your time and look forward to hearing any questions from you.